Hello, everyone. Thank you for joining us today for our Community Regional Coalition. This will be our final coalition meeting for our 12th scope of work. Go ahead and go to the next one, Mary. Just a little housekeeping. If you guys will please remember to mute your microphones. You could enter any questions that you might have in your chat boxes, and then that way we can kind of share everything with the group. Go ahead and go to the next one, Mary, for me. And then if you guys could go ahead and put your name and organization, your coalition name, where you're at. And then if you guys have any activities or updates that you might have going on so that we can capture those, we would appreciate it. Thank you. Okay, Mary, you can go to the next one, please. So today we're going to have some presentations from our data scientist, Liam Hedinger. He's going to go over some of our contract metrics and kind of do our celebration of where we've been over the last 5 years or so. We're also going to have Kyla Newland, an account manager, with us, go over our fall vaccine recommendations. We're going to give an update, a brief update of kind of the 13th scope of work and what that entails a little bit. And we're also going to have a presentation from Wyoming 211's program manager, Casey Quinn, on our Wyoming Community Information Exchange System. So if you want to move forward for me, thank you, Mary. And with that, we're going to start with Liam, and he's going to do our celebration of our contract metrics. So Liam, if you'd like to go ahead and get started for us.
Totally. Thanks for passing off. So part of our contract was we had some metrics to achieve. And so I'll go through this presentation. It's going to give an outline of kind of what that metric is and then our performance. And we're really going to be focusing on those ones that we did well in. So you can go to the next slide if you'd like. So the first metric that we're going to talk about is C. diff within nursing homes. So we were very successful with this, despite there already being low numbers of C. diff across our region. What we're looking at here is inpatient admissions due to facility-acquired C. diff without a related pre-existing infection, and our denominator is going to be short stay resident days in the reporting time period. So those are the amount of time that individual stayed in the nursing home. You can go to the next slide there. So we started out with relatively low numbers, and this very much was a battle against the low numbers. There was really not too many CDI cases across our region. So I think we started with just barely over 10 or something like that. But really saw some dramatic decline in those CDI rates throughout the terms of the contract. We did a lot of work directly with nursing homes to try to encourage some of this movement downward. And it's exciting that we achieved passing for this rate at the short stay level. So those residents that are in the nursing home for less than 100 days. You can go on to the next slide. The other set of metrics, so is a part of our 3-point metric, is blood pressure control among beneficiaries of hypertension. So we're really focusing on adequately controlled blood pressure among those beneficiaries that have hypertension. We looked at Medicare Part A claims, Medicare Part B claims, as well as get some beneficiary information from our benefit BIC table. And that's what develops this metric. And you can go to the next slide. So kind of at the start of this contract, we actually saw some declining rates, and we're really struggling with this particular metric. We started about halfway through the contract, started to see some significant improvement, especially coming out of states of Hawaii and Wyoming, although our entire region did help our rate within this metric. And it really was thanks to a lot of hospital associations committing to holistic record keeping of their patients. So typically billing codes are only billed for payment. They're kind of developed by accountants. And so that's what a lot of their primary purposes. But some of the hospital associations within Hawaii and Wyoming really committed to billing even codes that wouldn't necessarily result in payment. That holistic record keeping really allowed us to prove in this metric and was very beneficial, and is really the reason why we passed. And you can go to the next slide. So another metric surrounding chronic disease health is our hemoglobin A1C greater than 9% metric. So we were looking at beneficiaries with diabetes and those beneficiaries that had hemoglobin A1C less than 9% is really what the goal was. So in this metric, we were trying to get a declining rate because the numerator is counting the number of beneficiaries that have greater than 9% hemoglobin A1C. And the goal was to decrease that rate. Again, we looked at Medicare Part A and Part B claims in our big table for this. Again, a lot of kind of similar time frame as the 3.1 metric started to increase, and we started to kind of benefit from that rate. Was around the same time that our 3.3 metric also started to decrease. This is also kind of as a result of those holistic healthcare record keeping that I previously mentioned, but also a lot of direct interventions with the communities and trying to help those individuals with diabetes promote healthier habits. Yeah, so we ended up passing this metric as well. Our last chronic disease metric that we passed here deals with stage 5 CKD or ESRD diagnosis codes. And so we were looking at beneficiaries with CKD, and then the numerator is those beneficiaries with stage 5 CKD. So we're trying to reduce the number of beneficiaries that had stage 5 CKD. And you can go to the next slide there. Throughout the whole entire length of our contract, we really steadily improved in this metric. We saw much less cases of stage 5 CKD within our region. And that can be helped. That is helped by some interventions that working with hospitals to try to catch CKD early. That is kind of the biggest thing there, is catching it early is really the reason why we don't have a lot of these stage 5 cases. You can go on to the next slide. So we have two metrics we also passed within kind of care coordination is what they call this category. The first one is hospital utilization. So we're looking at all the fee-for-service Part A and Part B beneficiaries. So anybody that's enrolled in fee-for-service Medicare. And we calculated the number of emergency department visits, observation stays, and inpatient discharge, with the goal being to reduce those emergency department visits, observation stays, and inpatient discharges. For this metric, we just looked at Part A claims because those deal with hospital admissions, as well as our big table. Really, at the start of the contract is when we saw a major decline. There definitely is likely some COVID-related kind of decline within there. Our contract started, the baseline period was from October of 2018 to September of 2020. And then we had a sharp decline there at the beginning, and then have kind of been steadily under our 57-month target since the contract began. And then you can go on the next slide. So our next care coordination metric is deals with 30-day readmissions. So again, we're looking at, or in this case, we're actually just looking at fee-for-service beneficiaries with Part A, and then we're looking at the Part A claims database and the BIC table as well, and trying to reduce the number of 30-day readmissions among beneficiaries. So again, this followed a very similar trend to our hospitalization metric previously mentioned. We had a sharp decline at the beginning of the contract, and then steadily stayed under our target line for the remainder of the contract. These last sets of metrics are really around vaccination. So COVID vaccination was something that was introduced about halfway through our contract, and as the government adapted to more information, our contract came with lots of modifications within this metric. This particular metric deals with nursing home residents and trying to make sure that more nursing home residents have up-to-date vaccinations. That up-to-date tag is something that's defined by the CMS and the CDC. It's also changed as new vaccines came to market. And so this was one that we kind of very much changed throughout the entire of the contract, but ultimately ended in us passing this metric, which is very exciting. You can go on to the next one. So we're looking at our baseline period is different than the other metrics. It started in October of 2023, and we're only looking at a month of data for these metrics. If you notice on previous slides, the tables were looking at a year snapshot. In this case, we're only looking at a month snapshot. We started out in October 2023 with a vaccination rate among long-term, up-to-date vaccination rate among long-term long-term nursing home residents of 20% or 20.9, so almost 21%. And in the 10 months preceding, we increased that vaccination rate to 35.6% within those long stay nursing home residents. Go on the next slide. This definition very much follows the previous slide, but deals with staff up-to-date vaccination rates. We can go to the next one. And for our staff vaccination rates, we started at a rate of 7%. And by the preceding 10 months in August of 2024, we had a rate of 12.7%, about an 80% relative improvement rate there. And then lastly, our COVID metric deals with up-to-date vaccinations, but instead of looking at the nursing home population, in this case, we're looking at fee-for-service Medicare beneficiaries. This data came from Medicare Part A and Part B claims. Previously, the nursing home information is actually publicly available and comes from NHSN data collection. You can go to the next slide. Within all fee-for-service beneficiaries, we started out in October again of 2023, but unfortunately don't have data till August because there's a claims data delay that prevents us to get that data. But from October 2023 to May of 2024, we went from 15.7% to 25% up-to-date vaccination rate among fee-for-service beneficiaries. That's about a 60% relative improvement rate. So that is the last metric that I'm going to go over today. It's really impressive how well we've done in a lot of these metrics and how impactful everybody's effort has been in us passing these metrics. So thank you all for your hard work.
Hi. Liam, hi, this is Anita.
Hi.
Hi. Sorry, I kind of missed the metric 3.3. What was that one again?
That was dealing with, we're trying to reduce those beneficiaries with diabetes hemoglobin A1C score.
Oh, the A1C. Okay, thanks.
Thank you, Liam.
Yeah.
If anybody has any other questions, you're welcome to reach out to any of your account managers. You can leave a message in the chat and we can get back to you, or Liam's email will be on the PowerPoint and you're welcome to reach out to him directly as well. We do have Kyla Newland, one of our other account managers out of Alaska, that is going to be presenting next over our fall vaccine recommendations. So I'm going to let her go ahead and take over now so she can go over her information with us.
Thanks, Jen. Hi, everybody. Thanks for having me today. We can go to the next slide, and just transitioning from what Liam was talking about our metrics. We don't currently have, in our last contract, there wasn't an RSV vaccine, so that wasn't one of our metrics, but I anticipate it will be in the future. So as folks probably already know, we had our first 2 RSV vaccines approved probably about 1.5 to 2 years ago. And the original recommendations for folks to get this vaccine was everybody 60 and older. And then when the ACIP met in July, they decided they would adjust the recommendations and say that people 75 and older should receive this vaccine on a routine basis. And for our patients between 60 and 74, we should look at their risk factors to see if they should get the vaccine during that younger age range. So we can go to the next slide, which will show us which adults would be at higher risk and need to get it at a younger age. And I will mention also there's been some questions and confusion from some folks too as to whether you need to get an RSV vaccine every year, and that is incorrect. It is a one-time vaccine. So if folks got it when they were 60, when we have that current recommendation in place, they don't need to get another one at this point. And of course, we'll be able to see the durability and the length of coverage for that vaccine as we move forward, and that could change, but just making sure that that's clear, it's a one-time dose. So these are the conditions that would warrant you getting the vaccine at that younger age, between 60 and 75. So it's basically all of our folks that have chronic diseases, residents of long-term care, anybody that's immunocompromised. And then additionally, if a provider thinks that a patient's at high risk and they're not specifically fitting into one of these categories, that's a decision that they can make based on individual patient factors and giving that vaccine in the younger age range. And we can go to the next slide. And I will mention too, for RSV, there is a monoclonal antibody available, and that's going to be for our pediatric population, which I'm not going to go through today, but that is another option to cover our pediatric patients who are the other higher risk group for getting RSV. So moving on to flu, recommendations really have not changed from previous years. Everybody 6 months and older should get a flu vaccine by the end of October is what the CDC says. So right in the time frame we're in now, if you haven't gotten your flu vaccine, or if you've got patients that haven't gotten their flu vaccine, it's a perfect time to get it. We haven't seen a lot of flu activity yet in most of our states, but we do anticipate that to go up in the next several months. And our vaccines this year are going to be trivalent, so they're going to cover 3 different strains of influenza. And we can go to the next slide. COVID-19. So as many of you know, for this fall respiratory season, it is recommended that everybody get basically 1 dose of the most current COVID-19 vaccine, and that's going to be for everybody 6 months and older. So pretty much in alignment with our recommendations for flu vaccine. And there are currently 3 approved vaccines on the market. We have our 2 mRNA vaccines, and then we have Novavax also available for vaccination this fall. You can get your flu vaccine, your COVID vaccine at the same time. You can also get RSV. You can actually also get pneumonia. There's no restrictions on giving those vaccines together, but it is of note that if you get multiple vaccines on one day, especially as you add on, you might have a higher risk of getting those side effects that we expect. So things like low-grade fever, chills, headache, muscle aches, just feeling lethargic are very common. We can go to the next slide. So pneumonia vaccines, as many of you probably know, there was a new pneumonia vaccine approved just within the last probably year, and it's PCV21. And so when the ACIP met in July, they went ahead and added that to their vaccination schedule. So folks can either get that, or we have Pneumovax on the market, and we also have a PCV 20 on the market. And I can put links to those kind of tables that give you the recommendations for different age groups and risk categories if folks are interested, that will kind of guide you through that. There's also a really nice app from the CDC. It's called Pneumovax Rec, I think. And I can put that in the chat after I present as well. It's basically an app you can get on your phone. You put the patient's information in there. You put their previous vaccination status if they've had previous vaccines, and it'll tell you which vaccine is most appropriate for them. So that's kind of a handy tool. You can go to the next slide. And then last but not least, it is kind of shifting gears. It is National Drug Take Back Day. this coming Saturday. So definitely, if you don't know a location near you, you can scan the QR code here, or you can go to the National Take Back website. If you just Google it, and you can find a site to dispose of your unused or expired medication, so we can get those out of circulation and make sure they don't get in the wrong hands. And I think that's my last slide. Yep. Okay. Well, thank you. And if anybody has questions, feel free
I do. It's Anita again. Hi, Kyla.
Hi.
Just a couple of questions. So the COVID vaccine, if someone had COVID like earlier this year, or no, like a month ago, let's say someone got COVID a month ago, can they
Yep.
now get that new vaccine, or do they have to wait?
So the CDC says that they can wait 90 days because they have good protection, but
Okay.
they don't say that they absolutely have to wait any period of time beyond the recovery from COVID. So until all their symptoms are gone.
So that person, if their symptoms are cleared up, they can go ahead and get the new vaccine.
Yes, ma'am.
Oh,
Yep.
wow. Okay. And then about the pneumonia vaccine. So it's used to be you get the one shot and then a year later you get another shot. So is this same thing with
So
this new one?
that's a really good question. So they've actually simplified it with these two new vaccines, the PCV20 and the PCV21. If you get those ones, you don't have to get another one. But if you get a pneumovax, then you do have to get the other one. And I think it's 1 year later that you would have to wait to get the other one. So it just depends, like if for some reason you're not stocking the PCV20 or the PCV21,
Okay.
because they are a little bit more expensive, that might be a reason why you might not be stocking it. Although they should be covered under all insurance plans and Medicare. But basically, if you use one of those, you just have to give the one dose, which is nice.
Oh, okay, that's good. All right, thank you.
And I'll put those charts from the CDC in the chat as well. Those are really helpful.
Okay, thanks.
This is LaDonna, and I have a quick question for you. I do have the Pneumorex on my phone, and I think it's fabulous resource for figuring these out, algorithms. I just wondering, do I need to download a new one? Because I don't think mine has the PCV21 on it.
Ooh, that's a good question because I don't know if I've used it since. I'm assuming they've updated it because they updated all their other resources on the CDC website to include the new vaccine. And I would assume also that it probably just does automatic updates on that application.
Okay. The other quick question I had was, I was kind of noisy and I didn't get to hear everything you were saying about the RSV. I understand it's recommended, but it's also my understanding, last I knew, it was quite expensive and nobody was really paying for it or covering it. So
Yes.
it's not like a mandatory thing like the flu or the COVID for long-term care residents, is it?
So there's not like say reporting requirements on it yet, like with like NHSN and things like that. But it is covered under Medicare Part D, which is different than our influenza and our flu vaccine. And it should be covered by many commercial insurances now too, because it is part of the CDC's routine recommendation for people 75 and older. And people in long-term care would be in that 60 and older age range where it would be a recommended vaccine for them.
But don't you have to fill out your Medicare be out through a clinic? They don't do it for a nursing home, do they?
Yeah, that's been a barrier that we've heard from nursing homes, is that they don't have the capacity to build Medicare Part D, or they've never done it before and they don't have the infrastructure in place. And so in those cases, it would probably be best to partner with a local pharmacy because they can, and they're very versed in billing Medicare Part D because that's where all the other drugs go, and they're doing tons of RSV vaccines at the pharmacies. So if you need help getting in touch with a pharmacy in your area, we can definitely help you out with that as well, because we do have quite a few pharmacy partners across our region. Does that help?
Yes, thank you. Sorry, I was unmuting my audio. My fear is that I will leave it off mute. Yeah, thank you so much. Appreciate it.
Yeah, absolutely.
Hi, Kyla, this is Glynis. I just have a question regarding the shingles
Oh,
vaccine
yeah. Yeah.
because the doctor said that it's no longer covered by Medicare unless you have Part D. And a lot of people here in Guam do not have Part D or do not get Part D because it's expensive. And the shingles vaccine is super expensive. It's
Yes.
$200 per shot. So you're talking about $400. And I told my doctor I should have gotten it last year when it was still covered.
Yeah, that is a barrier that we've heard as well, with the shingles vaccine, and this it's just that same factor that it's under D, and
Yes,
that not everybody has coverage.
right. And our
So,
private insurance here, they don't cover it. If Medicare doesn't cover, they don't cover as well.
oh, that's interesting because
Yeah,
I know here they should be covering it. They're required to cover it. There can still
not in
be
Guam.
deductibles and copays, that apply, but that's too bad.
I know.
I would love to help you with that. If you want to have
I
offline.
sent an email to the director of CMS, Dr. Asby.
Oh, okay. Well, you're on
Haven't
it then.
received a reply. Thank
All
you,
right. Well,
Kyla.
thank you for bringing that up.
Thank you, Kyla. For our next presenter, works with Wyoming 211. He has a long-standing roots in Wyoming. Casey Quinn is his name, and he has been working to ensure that we have a prosperous future in the community, or that he has a prosperous community in Wyoming. He has a heritage while offering innovation for social and economic growth. He has led a career in advocating on behalf of people for Wyoming. It has been as a nonprofit lobbyist, government employee, and as an entrepreneur and business representative. Given his experience, he has developed strong skills in understanding interpersonal relationships between government entities and businesses and nonprofits. He is the current case manager for 211 and works to develop and manage and expand operations for Communicare, the new Wyoming 211 information or community information exchange. Sorry. So our local CIE. Casey, if you want to take control, you can of the computer now so you can do your presentation. Thank you for being here today.
Sure. Yes, Casey Quinn, program manager. No one wants me working their case, I can assure you that. Thank you to Jen and Mountain Pacific for inviting me to the regional group. I'm not new to Mountain Pacific, but I'm always learning new things about them and amazed at the amount of assistance and support you all offer to healthcare systems. Wyoming 211 works very closely with Mountain Pacific out here in Wyoming, and that relationship has grown substantially and more formally over the course of the last couple of years. Particularly in the realm of chronic disease prevention and working with Jen and Ben McGaugh out here. The presentation I'm going to share is more of my sales pitch that some people here, like Waikoa, have heard ad nauseum at this point. So apologies to them, but I'd like to take this time to be a little bit more informal and share and maybe discuss what we are doing. Oh, that's okay, Jen. What we were doing out here in Wyoming and what we've learned, why we ended up doing the things that we did. A lot of places have CIEs, a lot more do not, and those that do exist are completely different from one another because they serve different populations, both in the type of people and the size of those populations. So if you all are working with CIEs, maybe you all can get some ideas from me, maybe I could get some from you, and we can all reconnect at a later date to strategize. So I'm going to share this little presentation. What is my time, Jen? Just so I'm not taking over your regional meeting.
About 20 minutes probably. We need about 10 minutes at the end to wrap everything up.
Okay, very good. All right, so Communicare. So first of all, apologies if this is redundant for a lot of you. A lot of you might know what community information exchanges are. Elevator pitch, it's a centralized technology system that allows organizations to coordinate care. That means that they are logging onto a system. They are sharing case management notes, tools, care team tools. They are sharing follow-up notes. They are sharing documents, a shared client intake. And most importantly, they're sending bilateral electronic referrals to one another. So the example I have on here is pretty specific to healthcare, which is probably most relevant to you all, but I think just for the sake of time, a general use case is we work with a group called Enroll Wyoming. And Wyoming 211 has been big partners with them for some time, and they help deliver insurance to individuals. You give them a call, you don't have insurance, they'll help you find it and help you navigate the marketplace. We often send a lot of our individuals there. So they might receive a call from someone, and maybe there could be some assumptions made about that individual. They don't have insurance. Maybe that means they're without a job. Maybe they have outstanding medical bills. If they have those things, then maybe they're suffering from financial instability, which that could lead to 100 other things, from needing utility assistance and rental assistance. And then that compounds into mental health issues, which can then turn into substance use issues. So much can be said from that one single call in just trying to get health insurance. Formally, I think organizations, a lot of them would say, we just don't have those resources available. So then they can not do anything with that individual, or they would say, call your 211, which, that would apply anywhere in the United States. Call 211 and they'll at least give you referrals to relevant resources. And then they would either not see them again, or they see them a ton thereafter, weekly, especially if you're maybe not so much an insurance provider, but a food pantry or a hospital. Will see that client over and over and over again, because those thousands of other things that exist are not actually being treated, which very much is the foundation of the social determinants of health. So that's something we're trying to achieve here. And you can see how this applies in healthcare as well. Someone goes through the hospital, they're having cardiovascular issues, and then they get sent on their way, and then they're back again with a heart attack, high blood pressure, anything. What they need is maybe some diabetic management and education. They probably need better food choices and access to better food choices. Maybe those poor food choices come from a lack of income. And these healthcare workers, or those that work in the hospitals, can send that person out and know that they're getting those resources, and hopefully eventually that individual is able to be empowered enough to stay on top of things, and they won't have to see them anymore in the hospital. So Wyoming 211, again, this might be redundant. I'm sure this group is very familiar with 211s. Ours in particular began in 2011, and we're a nonprofit. A lot across the US are actually funded by their states. You're not going to get a lot of that out here in Wyoming. But Wyoming 211 is an information referral call center for the Health and Human Services. So you give us a call about any of those things that I had even just suggested, utility assistance, food, insurance, healthcare. We will make referrals to those organizations and track those. With that, we have also developed over a decade of relationships with communities out here in Wyoming. So the 211 is the perfect backbone for Communicare, to which Communicare is really just a program of this. There have been other organizations or companies that have come into Wyoming trying to attempt the bilateral referral module, but they're not part of that community, and that's probably where the biggest struggle is. They're good systems, it's just the people don't know the people. We also have 2,900 resources in the database, to which those are all accessible through the CIE as well. These are some of our partners. I think more for this group, this is to show the array of the types of organizations that we work with, all the way from small nonprofits to our single state university to hospitals in Cheyenne, Wyoming. This has grown substantially over the years. Also, to be frank, this presentation was outdated probably a few months ago. We're actually integrating into a new system, so it's going to look completely different, and I'm going to have to rebuild this thing anyways. hence the reason that is a little bit outdated. We offer different options for providers. We don't want to inhibit people with cost or with technology. If you're a small organization and you don't need all those case management tools, you can participate in our level 1, where you just receive emails and then you can accept, decline, and mark as provided services, put some notes in that the referring organization can then see. Or you're a large organization that needs care team tools. You do want to see case management notes. You do want to see a longitudinal client record. What have the referrals looked like for the last year or 5 years? So this is actually what is most outdated. However, the content remains relatively the same. Our intake, I think, was meticulously crafted. It was done so by our steering committee, which is that myriad of organizations. The development of this system has really taken over several years. Most of that was conceptualizing it, and then the last year and a half was actually building the thing. But the intake is meant to grab the least amount of information to make the most sound referral. So it tries to cover all the bases, but not to inundate staff or the client with too many questions. The best thing about this is client can go in and the information's already there. Also, if you screen people to a degree for whether or not you can give them services, it's all right here. And if it's not right here, we can add that to your intake and individualize it. Our referral module, this is, there's a number of ways to look for referrals. The idea is to get people connected to services that are relevant. So we train our partners on our taxonomy, but we also have kind of more of a Google function. They are supposed to be geographically relevant. So depending on the area code of the individual, the zip code, it will find those most relevant services geographically speaking. This is great in Wyoming because we will have people pop up clear in the northeast corner of the state and wind up clear at the southwest corner. And the people up there, you can never expect someone to know the services down in the other corner of the state, especially one as big as Wyoming. Also for referring people to larger communities, you might have a single doctor's office in a town of 500 people who is really the resource center, and they're referring out to what is our cities an hour away. This helps them navigate that and those services. And then also you can see what that referral looks like as it's requested. Here's some of our case management tools. These are going to completely change. We utilize the AHCM screening tool. We encourage our partners to utilize screening tools, and then we can cross-reference those. Any screening tool you want, we have it. And if you actually created one yourself, we can import that as well. And then this is our dashboard that just shows how these things work, or not how these things work, how the status of your referrals. When did I receive referrals? Do I need to respond to those? And then the referrals sent out, did they respond to it? What did they say? They declined it. Oh, that's too bad. I'll give them a call, the client a call, and we will find them a new service or try to find something else. Consent is probably one of the biggest processes of this. This is also something that's completely different. We want clients to have control over their information. This allows them to, pretty much checkbox anyone that they don't want to see their information. These organizations are not going to see their information unless they receive the referral or randomly looked up the individual, to which we have standards for that. But maybe this individual does not want Meals on Wheels to see their information, and they can remove that from their service provider consent list. HIPAA is obviously one of our biggest priorities. It is a HIPAA compliant site. We have multiple levels of auditing. We have third-party auditing. Our vendor does auditing. We do our own internal auditing. We have a pretty thorough privacy and data breach policy. If you're not HIPAA certified, we will offer HIPAA certification training. And then we also offer business associates agreements and QSOAs for organizations that handle PHI, so our hospitals and health networks, and QSOAs for substance use disorder, as there's another layer of legality there. We also offer navigators. So some of our organizations that are partners, they're smaller, but they see a lot of clientele that would be perfect for case management, and they can't offer that. They can actually make direct referrals to our Communicare Navigator, which we expect the staffing there to grow even more. We also host the Aging and Disability Resource Center and kinship program for those that are raising children that are not their own. So we did do a pilot program at the earlier part of this year. This was on a different system. It was a system that I just showed you, but it's actually telling more than anything. The system that we developed was a good system. It functioned, but it was just a little bit slower. It was missing some care team tools. So our pilot partners were actually doing a heavier lift than we were hoping that they would have. Despite that, they utilized the system and it went very well. We had 8 different partners within Laramie County. That's where Cheyenne, Wyoming is. And they ended up assisting 28 different clients, and then 271 referrals were made within the CIE during this project. 61 were made to CIE partners and 54 were made by CIE partners. And then, as you'll see, a good chunk of that was Wyoming 211 staff. They have more time within the system, and then this is also just what they do. So naturally, more came from there. However, half of them did come from our pilot partners. And then 22% of those referrals went to one of the 8 CIE partners. So we saw this actually work. We saw it on multiple occasions. And I got a dozen use cases that I could share with you regarding individuals and the success and the rate in which these people got services provided to them. I think mostly because of the CIE. Traditional referral would have just been a little slower. And for some of these individuals, a week or a month, that could be life or death. So the big thing that we did, and I think a lot of people see this, is interoperability is key to this system's success. A lot of case managers, nurses, people that work in healthcare industry or social services, they're already on multiple different systems. They're already in an electronic health record. Maybe they have a system that they're mandated to utilize by their grantors. It's difficult to have to hop onto another one, input new information into it, or even copy and paste it. So we had been trying to make this system interoperable for some time, and we had actually gotten connected to Contexture. Contexture is the health information exchange in Colorado and Arizona. Wyoming has one as well, but they're still in development, and I'm hoping one day we can connect to them. But right now, that's just not viable. So Contexture was the next best step. If you're not familiar with Wyoming, a lot of people go to Colorado for healthcare, same with Utah, and a lot of us go to Arizona as well to vacation and get away from the cold. So those HIEs already have a master patient index containing a lot of Wyoming individuals. In that, we met with the Community Resource Network, which was created by Contexture, and they were essentially the CIE for Western Colorado. What they showed us was basically a version of our system, just about twice as good with these connections. And we actually just signed the contract agreement for this last week, and we're doing our kickoff meeting tomorrow. So what this does is it does push back our launch a little bit. We were anticipating a September 30th launch. That's no longer going to happen. This pushes it back about 2 to 4 months, and then we will do a statewide launch. During this whole year, we've been fortunate to garner tons of partnerships in the form of partner agreements, invitations to networks, all those sort of things, because really the foundation of this thing working is relationships, not the technology itself. However, good technology will certainly make it work better. So we aren't at full launch. There are some programs or some partners that are using the system now, but we're not onboarding those new partners until early 2025. If you want to learn more about it, please go to wyoming211.org, and under programs and partners, you'll find Communicare CIE. We got onboarding forms, interest forms. Otherwise, I believe my email is I can put the email in the chat. Please reach out to me. I'm always wanting to meet with other organizations. We build off of San Diego CIE or South Dakota's or Wisconsin's, Pennsylvania's. And it still is a novel concept. So we all present ideas to one another and say, oh, I didn't think about that, or I haven't done that, or that wouldn't work here. So if you guys ever have anything for me, or you need something from me, please just shoot me an email and I'd be happy to chat with you. So thank you. If there's any questions, I'd be happy to take them.
Thank you, Casey. I will get that flyer dropped in the chat as well. And then I will, if you're gonna put your email in there, that would be great so that people can get in touch with you. And then if anybody has any questions, I'll let them go ahead and ask real quick.
Hey, Jen, this is Kyla.
Yeah.
I tried to put the flyer in the chat, but it's not allowing me to put an attachment in the chat. So I think we'll just send that out after the call if that works.
I put it into a Word document, so I should have it in just a minute.
Okay. I'll let you be tech savvy.
Okay. I'm hoping it works.
Okay, well, thank you all, and thank you, Jen, for the invite. I really appreciate it.
Yeah, absolutely. I think it's a good program to get everybody connected in one place and then be able to refer out and people can take it from there. But I think there is a struggle often where people kind of slip through the cracks or we don't know where things are at sometimes. So I do think it's a really good program. Okay, we just want to mention a couple things that we have coming up. As always, our Worth a Shot is every Wednesday. So if you haven't been coming or you need to get registered, we do have our registration link that will be available. So you can reach out and we can get going with that. Next, Mary. We have our link for our chronic disease and tools and resources. We also have our information on our go to the hospital or stay booklet that we have put together and our class checklist. And then we do have our website is new now. And so the layout will be a little bit different. So when you go to these, if you click on them and it doesn't look the same, maybe play around a little bit because our website has been changed. And so it's kind of fun to see the changes that have happened and how the flow is a little bit different. So any feedback would be greatly appreciated as well, because it does look very different now. Go ahead, Mary. Next page, please. 13th scope of work. Okay, so this is, we were going to briefly touch on the new 13th scope of work that is coming out. And so over the last 5 years, we have been in our 12th scope of work, and that is different, is ending now. And so we wanted to briefly kind of go over with you guys just a couple of things. Obviously, want to thank all of you guys for all the work that you guys have done with us over the past 5 years. The new contract has been put out by CMS. And so there's going to be some new quality initiatives that will be new work that will be related to activities that we've already been working on and focusing on, and then there'll be some new ones. The work that they are talking about will pertain to acute care hospitals, rural and critical access hospitals, as well as nursing home and outpatient clinical practices. And they have stated that the goal of the new contract will be to meet with providers and practitioners where they're at with their quality improvement activities, with a focus on some different initiatives than what we have been seeing before, maybe with a little bit of a mix of what we have already been doing. So they've listed things like preventing and better managing chronic disease, with the focus on diabetes and hypertension, chronic disease, and access to community resources, continuing to improve hospital and nursing home stays, improving in support and screening for depressive symptoms and substance abuse disorders, and managing chronic pain, improving care coordination across the settings and reducing readmission and avoidable emergency room stays, developing patient and family patient and family advisory councils to improve engagement with beneficiaries and families, and supporting providers and practitioners in quality management structure. We will continue to be working with CMS and other organizations during the transition time. Right now, the contracts have not been awarded, and so we will just continue to be in touch with our providers and with the agencies we've continued to work with over the next couple of months as we learn more information from CMS. But we did want to keep you guys updated on where we are right now, and to thank you for all of the work that you've done with us. I think Mark wanted to have something to say as well. So Mark, did you want to jump in there?
Just wanted to say how grateful we are and how wonderful it is to work with all of these communities from Montana, Wyoming, Alaska, Hawaii, and the U.S. Pacific territories. This was a new idea, the all-member meeting, and we found it very successful. The attendance has been consistent throughout. We appreciate being able to bring everybody together to share successes and lessons learned. And yeah, as Jennifer said, we're still in transition. We'll be here for a couple of months. In the meantime, please just keep up the great work. It's a privilege to be able to work with all of you. And obviously, Medicare wouldn't be the same if we didn't have all of these community members that we have the opportunity to work with. So mahalo to everybody. Thank you very much.
Yes, thank you, everybody. If you want to move on really quick for us, Mary, I don't think that we have much after this. Yeah, if anybody has any questions, I think that will put us at the end today, and then we'll keep in touch and let everybody know where we are in the next coming months. Are there any questions?
Hey, Jennifer, this is Anita again.
Yes.
Any idea when those new contracts will be awarded?
Not necessarily awarded, but they have mentioned that they're thinking work will start at the beginning of somewhere in January 2025 is what we've been told.
Okay, thanks.
Yeah,